Good morning, everyone. This is Dr. Deepthi speaking. I've completed my MS General Surgery and now being trained under Dr. SENADHIPAN sir as a fellowship training in Trivandrum. My topic today is perioperative nutrition, and I'm going to continue the presentation under ESPEN and ASPEN guidelines, that is European Society and American Society of Parenteral and Enteral Nutrition Guidelines. The topics under discussion will be under the following headings: metabolic response to trauma, methods of nutritional assessment, nutritional risk screening, perioperative nutrition per se, nutrition in sepsis, short bowel syndrome, and a short note on TPR and enteral nutrition. How important is nutrition and surgery? So, importance of nutrition, it has become widespread in all the fields of clinical practice. Particularly, it is important in general surgical practice or any surgical practices. Up to 50% of hospitalized patients can be classified as being malnourished, and many of the patients attending the IP or OP settings are not recognized clinically. Indeed, WHO has cited malnutrition as a single great threat for the public health. There was a study in Australian Nutritional Survey stating that there was a twofold greater risk of mortality due to malnutrition preoperatively, which was done in 2010. And the length of stay, which was compared between malnutrition and healthy people, it was concluded that the difference of length of stay is 15 versus 10 days of length of stay difference. And there was a twofold greater risk of mortality. So how the consequences of the nutrition in perioperative period? It impairs function at the organ and cellular level, and it impairs normal homeostatic mechanisms, due to which there will be mobilization of muscle stores, leads to muscle wasting, and due to the muscle wasting, the respiratory and cardiac muscle will be affected, the function will be lost, leads to atrophy of the muscles, which causes respiratory tract infection, pneumonia, and leads to death. And there will be a postoperative immune dysfunction and impaired wound healing. All these consequences leads to an increased risk of postoperative morbidity and mortality. So how the body tries to combat this surgical stress response? So as we know, there is a Newton's law: for every action there is an equivalent and opposite reaction. So in the same way, more or less in the same way, the body tries to combat this surgical stress, in a response what is called metabolic response to injury. When there are adequate preoperative physiological reserves in the body, these functional demands will be met with the physiological reserve. In surgical patients with low reserve, including malnourished, frail, and sarcopenic patients, they are vulnerable and leads to postoperative morbidity. This surgical stress response, the history dates back to 1878, when the physiologist Claude Bernard introduced the concept of milieu interior, which states that the body will be having an internal constancy. And further, the Dr. Walter B. Cannon extended the concept of milieu interior and introduced the concept of homeostasis. That is, the body systems try to maintain the internal constancy and homeostasis by release of adrenaline, and leads to flight or fight response, due to which the homeostasis is being maintained. In the early 1900s, these people were the people who introduced the concepts of surgical stress response. But unknowingly, Dr. George W. Kreil, who is a neurosurgeon practicing in early 1900s, he developed the concept to reduce the surgical stress response, and pioneered to reduce the pain and improve the recovery. He introduced the concept of local anesthesia and sedation, by which he called it as stress-free anesthesia, Kreil's concept of stress-free anesthesia. Nevertheless, Sir David Cuthbertson, who is the pioneer in evaluating the surgical stress response, and elaborated this surgical stress response in two phases. One is ebb phase and the other is flow phase. As soon as the injury occurs, the ebb phase starts, which is uh, um, the F phase starts, which will be continued till 24 to 48 hours immediately after the trauma. And later on, the flow phase will be started. Initial 24 to 48, there will be a initial F phase, which leads to decrease in metabolic response, decreased metabolic rate, decreased cardiac output, um, and it is superseded by this flow phase, which causes increased catabolic response, increased cardiac output, and increased adrenal. And along with that, in the flow phase, there are increased counter-regulatory hormones. The F phase and flow phase. The F phase actually, it is a phase which tries to conserve the body reserves. And during this phase, if resuscitation is started, there is a chance of attenuation of the surgical stress response, but not completely. And then it is replaced by the flow phase. Despite this advances in surgery, anesthesia, and intensive care support, death of the patient is inevitable if the F phase is not replaced by the flow phase. How the surgical stress response occurs is there is interaction between the central nervous system and the immune system. These two systems play a key role in continuing the surgical stress response. As the stress occurs, the injury occurs, there will be nociceptive pathways which will be traveling through the spinal cord, and the hypothalamus pituitary axis is activated, which due to release of ACTH and growth hormones and the activation of sympathetic nervous system, which leads to activation of hormones such as adrenaline, cortisol, glucagon, and insulin. Along with that, simultaneously, the immune system of the body will be activated, which leads to increase in inflammatory cytokines such as interleukin 1, 6, and 8. Combinedly, they act and leads to the changes in the body metabolism, such as adipocyte lipolysis, gluconeogenesis, glycolysis, and glycogenolysis. This can be seen in this figure. With injury, there will be neuroendocrine response leads to increase in the counter-regulatory hormones, that is catecholamines, cortisol, and glucagon, and there will be an inflammatory response, which leads to mobilization of the fats, mobilization of the protein stores from the muscle, and along with that, the liver tries to maintain the glucose levels by glycolysis, by gluconeogenesis, lipolysis, due to which increased metabolism and increased basal metabolic rate, urea will be produced more, and the kidney tries to excrete that urea. Usually, there will be a nitrogen loss of about 1 to 2 grams per day. But in the stress response, the nitrogen losses may reach to 15 to 20 grams per day. And gradually, the muscle stores, the body tries to conserve this muscle stores. Gradually, this proteolysis will be superseded by lipolysis. Due to lipolysis, there will be increased fatty acids, and these fatty acids will be utilized by heart and brain. This is the fuel economy, fatty fuel economy utilized by the brain to reserve the muscle stores. So by now we have understood that nutrition is important in perioperative period. But how to identify the patients who are malnourished? It is important to assess the nutritional status in all the patients who undergo surgery and identify who are malnourished and who are at risk of malnutrition. Usually we follow the practices of anthropometric measurements, biochemical, and functional measurements to in the clinical practice to identify the people who are malnourished. So coming to the anthropometric measurements, they are height and weight. Height, usually it is seen in children and indicates it is an indicator of chronic malnutrition. Coming to weight, it is a indicator of functional, gives a idea of fluid status and nutritional status both. So weight could not be taken as an indicator, sole indicator. There might be intense fluid shifts which may alter the body weight, and weight could not be taken due to this fluid shifts and all. There will increase in the not be taken as a sole indicator of nutrition. Coming to subcutaneous fat thickness, this can be measured in biceps, triceps. It is an index of subcutaneous fat thickness also cannot be taken solely as it is a good indicator, but solely it could not be taken as a nutritional indicator. Among the three, body composition, which includes BMI, fat-free mass, and fat mass, could be taken as reliable indicator of nutrition. So, coming to body mass index, it is a commonly accepted as indicator of nutrition. However, BMI can be misleading with the growing obesity pandemic. From this image, you can see there in the A picture, there is a good amount of muscle mass and a low amount of fat mass. In the B picture, there is a low muscle mass and a good amount of fat mass. Though the complete weight of this would be equal, the A and B would be equal, the lean body mass or the muscle mass will be more in A, and the lean body mass is low in B, due to which there is a difference in the post-operative morbidity and mortality comparing these two both. Amount of fat mass and free fat mass provides more valuable information than BMI alone, both in the functional and metabolic points. Bioelectrical impedance. This itself tells it is a biological indicator. By passing electrical current through the body, alternate current will be passed through the body, and the changes in the voltage will be estimated by the body by which the body is resisted. The voltage passed through the fat mass and through the lean body mass, that is the muscle mass, varies. The resistance occurred through the lean body mass will be lower than the resistance due to the fat mass. And this picture you can be seen in many fitness centers and all to distinguish between the lean body mass and the fat mass generally. And other imaging modalities which you can identify the lean body mass and the fat mass is DEXA scan, ultrasound, CT, and MRI. DEXA scan also gives lean body mass, fat mass, and bone density. This is a study by Coast and Riesinger et al., which is a study done on 310 patients, and preoperative CT has been done. And this study reflected the sarcopenia, frailty, and nutritional depletion, and it predicted the post-operative outcome after elective surgery, colorectal surgery. And the conclusion was there was they measured the 30-day in-hospital mortality rate, and the sarcopenic patients which were present, they have 8.8% mortality compared to 0.7 mortality in healthy patients. It gives only in-hospital mortality and could not predict the risk of anastomotic leak or sepsis. And these are the this is the CT which we can see the psoas major muscle, and this psoas major muscle it has been measured at the L3 level. And the cutoff value has been taken for as 52.4 for men and 38.5 for women. And below this level, the patient would be considered as sarcopenic, and measuring this level at the L3 level, the postoperative mortality and morbidity has been reviewed. Coming to the biochemical indicators, generally most of the proteins, total proteins, which are present as 50% is albumin. The T half of albumin is 21 days. Albumin generally it is an indicator of chronic malnutrition, and it could not give a good index of the acute nutritional status. Albumin is also a negative phase protein reactant, and it is lowered in malignancy, trauma, and sepsis even with adequate intake. It increases risk of complications. Albumin, there were studies previously in 1999. When you take the study, it is done by Henderson et al., and it was a multi-center study taken into account 44 tertiary care centers, and you could see the serum albumin when it is more than 4.5, the 30-day mortality is less than 1%, and if the serum albumin is less than 2.1, it was equivalent to 30%. And they concluded that preoperative serum albumin is more important, and it predicts the risk of postoperative morbidity and mortality. But the controversial point here is serum albumin, which is lowered in malignancy, trauma, sepsis, and in acute illnesses, could not be taken as preoperative nutritional indicator, because there will be transcapillary escape of the albumin in acute illness, due to which there will be a false decrease in the preoperative albumin and should not be taken as nutritional indicator. Other proteins which are used are transferrin, retinol binding protein, prealbumin. And compared to albumin, these proteins have a half-life which is low and could be considered for could be considered as an nutritional indicator in acute illness. These serum levels are also altered in stress and sepsis and cancer. But these are not readily available in all the institutes, and you are not routinely used in clinical practice. And this is CAR, that is CRP by albumin ratio, to assess the metabolic recovery. And it is a new prognostic parameter which has been validated. It was done by Ishizuka et al. In 2016, which in this study, they concluded that when the CAR ratio, that is CRP by albumin ratio, when it is less than 0.038, there was an improved overall survival when compared to high CAR ratio, that is more than 0.038. As I already told, if there is increased muscle stores mobilization, increased muscle loss, there would be increased urea elimination and increased nitrogen lost in the body in acute response, in acute phases of injury. So most of the nitrogen lost from the body excreted in urine and mainly as urea. Although nitrogen balance has not been shown to be a prognostic indicator, it is a useful way of assessing a patient's nutritional requirements. Coming to immune function, it includes parameters such as total leukocyte count, total lymphocyte count, and hypersensitivity reactions, but it varies with many conditions and it is not specific. And this muscle function could be assessed in normal cognitive people who are responding. This is a hand grip dynamometer, which is cheap and easy to perform, and it could be done for right and left limbs separately. It is difficult to apply in critically ill patients and who are not responding, and it is difficult in unmotivated patients also. Coming to malnutrition, according to SPEN guidelines, malnutrition can be defined as body mass index less than 8.5, weight loss which is more than 10% with indefinite of time, or more than 5% over a period of 3 months. Coming to low free fat mass index. This is what I told. This is the lean body mass, which is indicates the muscle mass, which is less than 15 in females and less than 17 in males. So individually, we can't take it as a nutritional indicator. So SPEN, it combines findings of unintentional weight loss and at least one of reduced BMI or low fat free mass index to define the malnutrition. So any one indicator could not be taken to indicate malnutrition. 2 or more indicators are needed to define the malnutrition status. As of now, there is no gold standard tool that is established to identify nutritional risk adequately. So the patients who are admitted, can be done, nutritional risk assessment can be done by certain scores, such as subjective global assessment, NRS 2002, must scores and all. This is a subjective global assessment is simple and reliable. Actually, it was developed by Detsky et al. In 1987, and it can be done in hospital at bedside. And it doesn't need any biochemical indicators or something. It is mainly dependent on patient's medical history and physical examination. The medical history may include the amount of weight loss, the dietary intake changes, any GI and functional impairments, how the food habits and all. In the physical examination, the loss of subcutaneous fat, muscle wasting, edema, and ascites are taken into account. Based upon these, they are classified as A, B, and C as well, moderately and severely malnourished. In the nutritional risk screening developed by Kondrup et al., based upon the indicators disease severity, weight loss, BMI, and food intake, they developed a nutritional risk that is score more than 3, there is a risk of malnutrition, and score less than 3, there is no nutritional risk. This is a nutritional score called Controlling Nutritional Status Corner Tool. It is a relatively new index developed by Ulibarri et al. In 2005. And it was based on serum albumin, total leukocyte count, and lymphocyte count. And they have classified as low, moderate, and severe based upon these 3 categories. So there was a study in 2020 in Mexico, in which 196 patients who were admitted in hospital, patients were taken into account, and the nutritional risk done after 48 hours. And these 3 scores were compared, and the results are The nutritional risk score and CONUT score detected the risk in 83%, and the subjective global assessment score detected 100% of the mortality rate. The instance of malnutrition is identified by subjective global assessment SGA score in 74% and CONUT score in around 50% and NRS score in 67%. So by this we can say SGA is a widely accepted method of detecting the nutritional risk, more or less in hospital patients, and it can be done bedside, and it is a reliable indicator. Professor Henry Kerlett, who was the pioneer of describing a perioperative care called as fast-track surgery or enhanced recovery after surgery, ERAS protocols, or multimodal rehabilitation after surgery. These are the ERAS guidelines in GI surgery, which includes preoperative, intraoperative, and postoperative guidelines. Generally, usual process which include long hours of fasting postoperatively as well as preoperatively, which unknowingly had an impact on the postoperative morbidity. And these ERAS guidelines were developed taking into account all these things, and there was pre-admission counseling, fluid and carbohydrate loading, no prolonged fasting, and such all these guidelines were developed to decrease the postoperative outcome, length of stay, morbidity, and mortality. So in the pre-admission, I'm not going into the details of everything, selectively concentrated on the nutrition aspect. Coming to the pre-admission, 4 to 8 weeks of abstinence from smoking appears necessary to reduce respiratory and wound healing complications. As any elective cases, smoking should be withheld 4 to 8 weeks for postoperative good healing of the wound and postoperative morbidity. And ASA recommends minimum hemoglobin concentration of 6 to 10 grams per deciliter, and should be maintained throughout the perioperative period. In the preoperative phase, as I told you, long hours of fasting are abandoned, and now clear fluids can be given until 2 hours and solids can be given until 6 hours. By this, there would be adequate glucose load in the body, and postoperative insulin resistance will be reduced. But you have to be taking care that this preoperative fasting and all are contraindicated in or reduced. The time should be increased in delayed gastric emptying, emergency surgeries, and GERD, in which there would be exacerbation of reflux and all. So coming to carbohydrate loading. What is this carbohydrate loading? The preoperative carbohydrate treatment. Preoperative carbohydrate treatment instead of overnight fasting, also called as carbohydrate loading. This carbohydrate loading, which includes 800 ml of dextrin, maltodextrin, which is given 800 ml the night before and 400 ml 2 hours before surgery, had an impact on the postoperative outcome. There was a study done by William J. Fawcett and it was given in British Journal of Anesthesiology, and it was a meta-analysis in 2017, which stated that there was a decrease in mortality of about 25%. So preoperative starvation is abandoned and carbohydrate loading must be done in these patients. Common brands in UK are preload and pre-op, and generally all the glucose preparation should not be given, and the complex carbohydrates maltodextrin must be given. It impacts postoperative insulin resistance, improves patient well-being, does not increase the risk of aspiration, and specifically caution must be taken in patients type 1 diabetes mellitus and severe diabetes mellitus patients, in which this maltodextrin is contraindicated and it is not advised preoperatively. So we have identified the patients who are at risk of malnutrition. So when to start this nutrition therapy and how to start? So based upon this guidelines, nutritional risk scores and nutritional risk assessment, ESPAN has devised 5 criteria for nutritional therapy. That is weight loss more than 10 to 15% within 6 months, BMI less than 18.5, SGA score grade C or nutritional risk score more than 5, and preoperative serum albumin less than 3 grams per deciliter. So how to give this nutritional therapy? So initially, the patients who are undernutrition, preoperatively, who are undernutrition, first the correction of undernutrition must be done. And the patients at risk of malnutrition should receive this nutritional therapy. Whether it may be enteral or parenteral, it should be given for 7 to 10 days preoperatively. And Immune modulating nutrition such as supplements of arginine, omega-3 fatty acids, and nucleotides can be given 5 to 7 days preoperatively. Even this immune modulating nutrition, which has a impact on postoperative decrease in morbidity and mortality. If it is anticipated that patient will be unable to eat for more than 5 days perioperatively, and if the patient is expected to have low oral intake and who cannot maintain more than 50% of the recommended intake for more than 7 days, preferably in any case, when the GI tract is functioning, preferably enteral route must be taken, and without delay. In these cases, when it is anticipated that perioperative malnutrition, perioperative nutrition could not be taken enterally, and then parenteral nutrition should be taken. So this is a study by Tekaro Miyazaki in 2008, and it was a meta-analysis showing that enteral nutrition and parenteral nutrition, comparing these two studies, and enteral nutrition has a more increased favorable results postoperatively than parenteral nutrition. Enteral nutrition, as we use the GI tract, there will be immunomodulation, there will be use of this increased the villus atrophy will not be there, immunomodulation will be there, and less risk of infections compared to parenteral nutrition, which we use central lines and all, and there will be increased risk of infection. So recent ESPAN guidelines recommend that postoperative parenteral nutrition for patients who cannot meet their energy needs orally or enterally, less than 50% of the calorie requirement within 5 to 7 days, and start parenteral nutrition when the patients are malnourished, and postoperatively when the risk on day 4 at the latest. We can start parenteral nutrition when you diagnose that the patient is not able to take the nutrition by enteral route. And if the predicted perioperative intolerable enteral nutrition is for 4 to 7 days, you can have a PICC line, that is peripherally inserted central line. And if it is more than 7 to 10 days, we have to go for a central line insertion. So this is a study for perioperative immunonutrition, which includes arginine, glutamine, omega-3 fatty acids, and ribonucleotides. This is done by Pedro Mayo et al. In 2016. That is called SONVI study. And they have given 7 days before preoperatively and 5 days postoperatively. And they found that there was a significant decrease in infectious complications when it was 23.8% without this immunonutrition, and decreased to 10.7% with immunonutrition. Along with that, the concept of eco-immunonutrition, which is formally containing symbiotics such as fiber and lactobacillus. This was a study which includes 4 probiotics, that is lactobacillus, 2 strains of lactobacillus, and it was done by Katrina et al. In 2015, which was given 1 day pre-op and 15 days post-op. And there have been a significant reduction in the rate of post-operative pneumonia, surgical site infections, and anastomotic leakage. So coming to antibiotic prophylaxis, this was a study in Minch and et al. In 2016. Initially, only oral systemic antibiotics used to be given. But now with this study, they have concluded that oral antibiotics along with mechanical bowel preparation has a significant decrease in surgical site infections and incisional hernia compared to systemic antibiotics and mechanical bowel preparation. So coming to bowel preparation, previously, there have been a thought that mechanical bowel preparation is recommended only for rectal cancer surgery, and it is not useful for colonic surgery. No benefit of MBP in terms of surgical site infection or anastomotic leakage. This was a study done by K. Lee et al. And they have concluded that colorectal mechanical bowel preparation is not required and no benefit of mechanical bowel preparation. But gradually the trend has been changing, and the combination of mechanical bowel preparation and oral antibiotics had a significant advantage over mechanical bowel preparation alone. But mechanical bowel preparation along with systemic antibiotic prophylaxis has no clinical advantage. Coming to intraoperative guidelines, it includes pre-medication, epidural analgesia to reduce the postoperative pain, to decrease the sympathetic response, and improve the patient well-being postoperatively. Goal-directed fluid management, such that dumping of fluids intraoperatively, which leads to weight gain, fluid imbalance, Postoperatively, it may lead to postoperative ileus. It may lead to delayed gastric emptying and postoperative nausea and vomiting. So goal-directed fluid management should be instituted, and minimal tissue handling and minimize hypothermia. Last but not the least, minimal access surgery, which decreases the stress response of the surgery compared to the open surgery. Coming to the postoperative guidelines, early oral diet has been shown to be safe 2 hours after, 24 hours after surgery. ASPEN guidelines too recommend early enteral nutrition within 24 hours. This was a study by Lewis Anderson et al. And Thomas et al., which was a meta-analysis in 2009 showing that early enteral nutrition within 24 hours of intestinal surgery is had a decreased postoperative morbidity versus late commencement of feeding. Postoperative nausea and vomiting. Why this postoperative nausea and vomiting is important is 30% to 50% of all surgical patients and up to 80% who are at high risk have developed postoperative nausea and vomiting, due to which enteral nutrition is not intolerable and may lead to postoperative weight loss and may lead to postoperative complications due to inadequate nutritional therapy. So there existed a multimodal approach for this postoperative nausea and vomiting prophylaxis, which concluded that this study concluded that DREAMS trial concluded that a single dose of 8 milligrams intravenous dexamethasone at induction of anesthesia reduces both the incidence and postoperative nausea and vomiting at 24 hours postoperatively. So preemptive medication of patients who are at risk of postoperative nausea and vomiting by APSEL score, when we give the medication preoperatively itself, there are chances of reduction of postoperative nausea and vomiting. When there are 1 to 2 risk factors, one medication is sufficient. When there are more than 2 risk factors according to APSEL score, 2 or more medications of different mechanism of action can be given. So postoperative hyperglycemia, why is it important? So postoperative, as we know, in this surgical stress response, there occurs an insulin resistance, which leads to hyperglycemia. And due to hyperglycemia, there will be increased risk of infections and postoperative morbidity. So Anna Frisch et al., who has done this study in 2010 in Atlanta, there was evidence supporting an association between the presence of diabetes and significantly elevated risk of 30-day mortality. So a mortality risk of 2.3% has been observed. The patients who are diabetics preoperatively and patients who have found de novo diabetes preoperatively. De novo diabetes have an increased risk than diabetics who have diagnosed before itself. Coming to postoperative insulin resistance. So this insulin resistance, as I told you, hyperglycemia, which has an increased morbidity, it can be diminished by this metabolic conditioning. What is this metabolic conditioning? As previously stated, this carbohydrate loading before surgery preoperatively, the night before and the morning before 2 hours before surgery, has an impact on postoperative glucose levels, and epidural analgesia, which decreases the stress response and decreases pain and increases well-being of the patient. Immediate enteral nutrition postoperatively. These three constitutively called as metabolic conditioning decreases postoperative insulin resistance. Postoperative ileus. So postoperatively, the common problem which occurs is postoperative ileus, due to which the patient will not be started nutrition as soon as the ileus could not be resolved. So how to prevent this postoperative ileus? Should limit the opioid administration through use of multimodal anesthesia and analgesia techniques, because opioids are the drugs which exacerbates postoperative ileus, and resort to minimal invasive surgery and gentle surgical techniques in order to minimize the trauma. And again, fluid management, because increase in the fluids and dumping of the fluids leads to tissue edema and exacerbation of the postoperative ileus. Elimination of nasogastric tubes, and a recent study, peripherally acting mu opioid receptor antagonist, that is albumin, which is a strong evidence that this reduces postoperative ileus. And other things which includes chewing gum, biscodal, magnesium oxide, and coffee, which are weak evidences that postoperative ileus could be resolved. There was a study in 2018 by Ajay Singh Kalyanavat et al. And indicating that postoperative ileus, the role of chewing gum to reduce its duration. They have done this study on the basis of cephalic vagal reflex, due to which this reflex there might be a decrease in postoperative nausea and vomiting, postoperative ileus, sorry. Coming to nutrition in sepsis. Till now, we have dealt with perioperative nutrition in elective surgeries. So how different is nutrition in sepsis? Sepsis is a common surgical a common problem in surgical patients, and its presence influences the outcomes in those to undergo surgery. So even with advanced techniques, perioperative anesthesia, advances in surgery, there could be increased mortality. There are evidences of increased mortality even with these techniques. So why this sepsis plays a role? It is a continuous catabolic state. The nutritional therapy in elective surgeries and nutritional therapy in sepsis, why it differs? There is a exacerbated catabolic state compared to the elective surgeries, and this exacerbation and this nutritional therapy should be more increased, more nutritional therapy should be more should be aggressive. The nutrition support should be aggressive even in the septic patients. And these what are the requirements in sepsis? So in general, the normal protein intake are generally less, about 1 gram per kg per day. The requirement in sepsis, the protein intake will be increased, and in sepsis, the proteins gradually should be increased. That is, less than 0.8 is called low protein intake, more than 1.5 is high protein intake. Initially, the protein should be started around 0.8 to 1.2 grams and should be increased gradually. The lipids should be given at 1.7 to 1.5 gram per kg per day. Glucose 1 to 1.5 grams per kg per day. Glutamine, which is a gluconeogenic hormone, which is the amino acid which it is important in gluconeogenesis. It should be given at less than 0.35 grams per kg per day IV or 0.5 grams per kg per day in enteral or enterally, and fluids 1 ml per kg per hour. So the energy requirement, which should be energy requirement should be calculated based upon the indirect calorimetry method, by which the patient is connected to a ventilator and the volume of oxygen or volume of carbon dioxide exhaled must be measured, by which the energy requirement is developed. The energy expenditure should be calculated as total energy expenditure is equal to resting RE plus additionally the stress factor and activity factor must be included. So this is a resting energy expenditure. In partial starvation, the stress factor must be subtracted by 0 to 15%, and based upon the mild, moderate, and severe infection, addition of 13%, 10 to 30%, the stress factor must be added, and the total energy expenditure should be calculated based upon that. So, how to give nutritional therapy in sepsis? So, this is the part. Anywhere in elective or emergency surgery, when the GI tract is functioning, prefer GI tract over parenteral nutrition. So first, oral supplements should be given. Preferably, oral supplements should be preferably given than enteral nutrition or parenteral nutrition when more than 70% of the needs of the body, that is more than 70% of the calorie intake, if it is supplemented by this oral feeds, it can be preferably used. When this oral supplementation cannot be done, and then early enteral nutrition should be done. And now early enteral nutrition, when it should be started, whether it should be started immediately in the critically ill patient or after 48 hours. Early enteral nutrition, initially they thought that early enteral nutrition should be preferably done than delayed enteral nutrition. But in critically ill patients, when already hypotension is there, when already patient is critically ill, if you supplement the nutrition by enteral nutrition, there will be decrease in the splanchnic blood flow and it exacerbates ischemia and sepsis. So early enteral nutrition less than 48 hours is not advised. So enteral nutrition should be started more than 48 hours, such as day 2 or day 3 in an ICU patient. If enteral nutrition could not be given in cases such as fistula patients, GI losses, short bowel syndrome, in more than 50% of burns, in that cases when enteral nutrition could not be compatible, and early parenteral nutrition should be instituted. When early parenteral nutrition should be started, preferably again the first 2 days should be omitted, and 3 to 7 days after the admission parenteral nutrition should be started. And bolus tube feeding versus continuous tube feeding. So when given through the enteral nutrition, which is preferred, bolus feeding or continuous feeding. So this continuous tube feeding has the advantage of decrease in the diarrhea, and this bolus feeding, it has the advantage of decrease in the aspiration. So continuous tube feeding, according to SENADHIPAN guidelines, continuous tube feeding is preferred over bolus tube feeding. Coming to this was a study by Singer et al. In 2019 comparing early enteral nutrition versus early parenteral nutrition. This was a meta-analysis, and this study showed favorability of early enteral nutrition than early parenteral nutrition. So enteral nutrition has no proven clinical benefit over parenteral nutrition and is associated with more digestive disorders. However, when the gut works, we recommend using it. And now this Nutriria tray. What is this tray? So full enteral nutrition should be avoided during the acute phases of septic shock. Why? Because when you give complete enteral nutrition through this, as I already told, there would be exacerbation of ischemia of the bowel due to decrease in splanchnic blood flow. And along with that, full enteral nutrition, when it is given, it leads to overfeeding, which should not be occurred. So this overfeeding leads to refeeding syndrome. So full enteral nutrition should not be started in first 48 hours of patient who are admitted in ICU or who are critically ill. So parenteral nutrition in these cases may be a safer route when enteral nutrition is not indicated. So the conclusion is early enteral nutrition in combination with supplemental parenteral nutrition to reach at least 80% of the caloric needs should be started by day 3. Again, this early phase, delayed phase, and when in more than day 3. In sepsis, if the resting energy expenditure is 100%, should not give the resting energy expenditure to 100%. It should not be given. A hypocaloric nutrition should be is advised. That is about 70 to 80% of energy expenditure is optimum to maintain the survival and maintain the nutritional needs of the septic patients. In delayed phase, that is after more than 2 to 3 days of the critically ill patients, isocaloric nutrition can be given. The idea behind this hypocaloric nutrition is again to avoid overfeeding. As because in the early phases of surgical stress, there will be an endogenous production of this calories, which accounts to 500 to 1400 kilocalories per day. And if again isocaloric nutrition is advised in this early phase, there would be overfeeding, which leads to refeeding syndrome and complications. So hypocaloric nutrition is advised in early phases. So the optimal caloric load associated with best survival is around 80% of the predicted energy needs. So, as you can see, the patients in septic shock, initially no nutrition is advised when the patient is in shock, that is mean arterial pressure less than 65 mmHg and lactate levels more than 2. As gradually the shock decreases, the patient is improving, and patient with organ dysfunction and SOFA score more than or equal to 2, gradually the nutrition must be started, which includes calories and proteins. The thing is, hypocaloric feeds must be given initially, which should be changed to isocaloric, and proteins initially it should be low, that is around 0.8 to 1 grams per day, and gradually increase to more than 1.5 grams per kg per day. And when these patients survive the sepsis, the patient will enter into PICS, that is post-inflammatory immunocompromised syndrome, which is detrimental to patient in terms of decreased in terms of increased length of stay, cognitive decline, mortality, and morbidity. So This calories and protein should be adequately substituted in the septic phase and gradually increased over this phase. Coming to nutrition in short bowel syndrome and in EC fistulas. So the goal of management of this short bowel syndrome is um, short bowel syndrome generally occurs due to resection of the bowel. Intestinal failure is the condition in which short bowel syndrome is one of the condition of intestinal failure. There is a condition where the absorption of the nutrients will be decreased in conditions like celiac proofs like that, which leads to intestinal failure. So the goal of management in these cases should be optimize the hydration, nutritional therapy, avoid small bowel bacterial overgrowth, and minimize the duration of parenteral nutrition. Why this hydration is important? Generally, when enteral nutrition is present, an effluent of about 8 to 9 liters occurs through the small intestine to the colon. When it reaches distal ileum, about 90% of the effluent is absorbed. And when it reaches colon, an amount of 150 ml is excreted through the feces. So there occurs an intense absorption efficiency in small bowel and colon. So when this bowel is resected, specifically, particularly this ileum and colon are resected, there causes an intense loss of absorption and causes dehydration. So the main goal of the management is optimize the hydration therapy and nutrition therapy. As again I told you, along with absorption of water and sodium, there occurs an absorption of nutrients. In the more of in jejunum, there will be absorption of fats and amino acids, proteins, more than ileum. So nutritional therapy should be instituted. So again, if the colon is resected, there will be a loss of ileocecal valve will be absent, and there may reflux of the bacteria may occur, and it may cause small bowel bacterial overgrowth, again which leads to sepsis and increased morbidity, and minimize the duration of parenteral nutrition. Many of the patients, more than 50% of the patients who undergo this resection and short bowel syndrome were dependent on parenteral nutrition. So should minimize the duration of parenteral nutrition. So this is a picture just to give an idea of the location of the nutrients where the absorption occurs. Particularly in duodenum, the minerals such as calcium, iron occurs. In the early parts of jejunum, there occurs the absorption of amino acids, saccharides, and fatty acids. In ileum, particularly, there occurs absorption of bile salts and vitamin B12. And along the whole length of the bowel, water and sodium occurs, and colon has the specific feature of absorption of water and chloride specifically, which is a when the short bowel syndrome patients, when the colon is present, that would be a advantageous factor for them. So in general, short bowel syndrome, resection of about 50% of the bowel length could be tolerated by the patient without any nutritional deficit. But if more than 100 centimeters of the ileum is lost, it leads to malabsorption and leads to steatorrhea. If more than 60% of the 60 centimeters of the distal ileum is lost, it leads to vitamin B12 deficiency, and vitamin and supplementation of vitamin B12 is needed. So what is colon versus no colon? So as I told you, when colon is present and when colon is absent, the nutrient intake will be almost same. But particularly when you come to this fats, colon has a peculiar feature of anaerobic metabolism. That is, the bacteria which are present in the colon undergo this anaerobic metabolism and convert into short chain fatty acids, due to which there will be increase in the salvage of about 1000 kilocalories of energy. So when the colon is preserved in short bowel syndrome patients, 20 to 30% of energy intake is needed. And when colon is absent, additional intake of 30 to 40% of energy is advised. And again, in this colon, when colon is present, the oxalates must be restricted. Why? So when there is fat malabsorption, the fats which will be combined with calcium, and they form a complex thing, fats along with calcium. So oxalates will be free, and they are absorbed back into the blood. So which leads to oxalate stones or nephrolithiasis. So oxalates must be restricted when colon is preserved in short bowel syndrome. So no restriction is necessary in when colon is resected. And again, when colon is present, oral rehydration solution and hypotonic solutions are preferred. And when colon is absent, ORS is preferred. So these are the requirements in short bowel syndrome. The energy will be, it will be 20 to 35, and it may increase to 35 to 40 kilocalories per day, depending upon the needs. Proteins will be same as in septic patients, 1 to 1.5. The lipids will be reduced, less than or equal to 1 gram per kg per day should be maintained. And the glucose needs must be increased. That is, it may reach about 6 grams per kg per day. And in the fluid requirements are also increased, particularly in ostomy patients. It may reach about more than 3 liters per day. So how this dietary management of short bowel syndrome is done? Adaptive hyperphagia, that is, small amount of multiple meals must be taken to reduce the amount of diarrhea that the patient is facing. So that is called adaptive hyperphagia, small amount of multiple meals. And again, increasing caloric needs are done, and carbohydrates, which are complex carbohydrates, are preferred than simple carbohydrates, such that the complex carbohydrates are resistant to digestion and may increase the transit time and decrease the postoperative diarrhea. And again, soluble fibers are more preferable than insoluble fibers. When colon is in continuity, fats are reduced. As I told, anaerobic metabolism will be present. High calcium is required because the bile salts, which are malabsorbed, form complexes with calcium. So by that, the calcium will be reduced. So high calcium is required and low oxalate, and medium chain triglycerides are required. What about this medium chain triglycerides? When colon is in continuity, when compared to long chain and medium chain triglycerides, this medium chain triglycerides have the peculiar feature of absorption through the bowel lumen. So when colon is preserved, this medium chain triglycerides are particularly preferred, so that these will be absorbed more and added to the diet. Compared when short bowel syndrome with end ostomy, they can tolerate a higher fat at about 30 to 40% of the calories. So the drugs given in short bowel syndrome, these are the anti-secretory drugs, which are preferred are H2 receptor antagonists and proton pump inhibitors. There will be increased GI secretions. Why? Because the gastrin, which is secreted, the inhibitors of gastrin are lost when due to the resection, and there will be increased hypergastrinemia, due to which hypersecretion of acid will be there. So anti-secretory drugs are needed. Anti-motility drugs, there will be increase in transit time. So these anti-motility drugs such as loperamide, codeine acts to decrease the transit time. And resins, due to the loss of ileum, most of the bile salts are absorbed in the ileum by enterohepatic circulation. So when the ileum is lost, the bile salts will be malabsorbed and they reach the colon. So due to which the colon will be acted by this detergent action of this bile salts and causes choleratic diarrhea. These resins such as cholestyramine binds to the bile salts and decreases the malabsorption of the bile salts. But this is a double-edged sword, which includes when this malabsorbed bile salts are binded with these resins, there is an increase in the steatorrhea, which is detrimental again to the patient. This anticholinergic, somatostatin analogs, all these are used to decrease the amount of intestinal secretions in the body. Somatostatin analogs have been used to decrease the secretions, but there is a little evidence about the somatostatin analogs that it inhibits the intestinal adaptation. When the patient is small bowel is resected, in the postoperative phase, there includes an acute phase and an adaptive phase. Acute phase accounts for 1 to 4 weeks, and after 4 weeks, the adaptive phase starts, which includes which extends for about 1 to 2 years. So when these somatostatin analogs are used, there is an evidence that it might inhibit this intestinal adaptation, due to which the patient will not able to tolerate the enteral nutrition feeds. So it should still evidence must be present for the somatostatin analogs. And GLP-2 analogs. GLP-2 analogs are sitagliptin, which are used to increase the incretins. And the incretins, glucagon-like peptide 2 analogs, these are the substances. These are used to increase the immunonutrition of the bowel, and this enhances the trophic effects of the bowel lumen, so that the enteral nutrition will be tolerated more. And Zobtiv it is a new drug which includes recombinant growth hormone. And when the Zobtiv along with glutamine and all it is given, there occurs a postoperative increase in transit time and postoperative decrease in mortality and decrease in mortality. So, enterocutaneous fistula. All the above things which are discussed in short bowel syndrome will be applicable to EC fistula, and specifically discussing about this distal feeding. Distal delivery of the feeds exercises negative feedback on biliopancreatic secretion, the so-called ileal brake. So, when the bowel is resected, the nutrients entering the distal lumen will be lost, and the ileal brake is lost, such that there will be dumping and increase in the transit time. So specialized techniques such as fistuloclysis or chyme reinfusion should be considered. This reduces the need for parenteral nutrition. This is a type of external circuit by which the proximal enteral feeds are introduced into the system, and they are fed distally. So this chyme reinfusion convincingly showed that there are evidences to normalize liver parameters such as alkaline phosphatase, gamma glutamine transpeptidase, and there will be decreased liver disease. As we know, with parenteral nutrition, there will be increased lipid deposits and increased liver dysfunction called as PNALD, like parenteral nutrition associated liver disease. With this chyme reinfusion, there decreased the requirement of parenteral nutrition and liver disease also. So this was a study by Picot Dennis et al. In study was done over a period of 18 years, and this nutritional status improved with respect to weight gain and albumin. And this study has concluded that there is a postoperative improvement in intestinal losses also. The intestinal failure has resolved, and there is a decrease in hepatic function also. So coming to various modes of nutrition, as we are now discussed, there are two modes of nutrition. One is enteral nutrition and parenteral nutrition. So parenteral nutrition, it can be given through central route, and also it can be given through peripheral route. Enteral nutrition, it can be tube feeding or it can be gastrostomy feeding. So coming to total parenteral nutrition, this total parenteral nutrition dates back to 1962. Before that, there would be before 1962, if anyone says nutritional therapy or parenteral or nutritional therapy in case of intravenous nutritional therapy, there was evidence only of dextrose and electrolytes only. But in 1962, lipid emulsions were identified, and in 1966, Dr. Stanley J. Dutrick, who was a practicing surgeon and he was now considered the father of nutritional support, he has invented this intravenous therapy of parenteral nutrition. Later on in 1976, Solosol and Jerks, they have discovered the 3-in-1 solution, and later home parenteral nutrition has been discovered. So these are the types. Initially, there had been a 1-chamber bottle, and then next 2-chamber bottle that includes amino acids and glucose, and later on 3-chamber bottle has been developed, and these are intralipid emulsions which can be given separately when this 2-chamber bottle has been given. This is a microfilter which will be used for this parenteral nutrition therapy. See, these are the previously compounded bags are there, and now multi-chamber system has been followed. The compounded bags are nothing but the individual nutrients are compounded into a single bag, and they have been constituting simultaneously and will be infused to the patient. There will be a compounding machines which do this job. The hospital staff will mix this parenteral nutrition formulas themselves previously, and later this compounded bags system machines have come into action. So these compounded bags are more complex, and compared to multi-chamber system, there is a low risk of harboring contaminants and bacteria, because this multi-chamber system, it has a pre-mixed solution which has very less handling by the hospital staff, and it is easier comparatively. The compounded bags, the shelf life is about only 7 to 9 days compared to multi-chamber system which includes 12 months or more. The only advantage of compounded bags is that such that the dose can be adjusted according to the needs, and more protein and electrolytes can be infused, which can't be done and which cannot be tailored in multi-chamber system. So in metabolic needs, and sepsis or ICU patients, these component bags can be helpful. So coming to the constituents, the composition of parenteral nutrition, mainly it includes macronutrients, that is dextrose, amino acids, and lipids. Along with that, the micronutrients, minerals. Along with that, micronutrients, minerals, electrolytes are also present. So coming to the macronutrient dextrose, it is the primary energy source. It constitutes about 70%, that is 70 grams per 100 ml, and it gives a calories of 3.4 kilocalories per grams. So the total kilocalories which are present is 45 to 60%. Amino acids, it can be of 10%, 15% emulsion, 10%, 50% constituents, which contains 10 grams per 100 ml and 15 grams per 100 ml. It is a hypertonic solution which gives a 4 kilocalorie energy level. Coming to the fat, it is a 20 to 40% of total kilocalories. Most common is 20% is soybean oil emulsions. The fats which includes, initially the fats which were included was soybean oil emulsions, which later on the second generation came medium chain triglycerides and soybean oil in 50 to 50 composition. Later on, the soybean oil has been completely abandoned, and now the fourth generation oil emulsions, which include fish oil emulsions. The thing with why soybean oil has been abandoned or decreased in the formulation is it leads to pro-inflammatory activity. It has a pro-inflammatory property which constitutes omega-6 fatty acids, due to which there are increase in the infections and increased complications. But with fish oil and olive oil, which are the fourth generation oil emulsions, they have immunomodulatory properties which consist of omega-3 fatty acids along with docosa pentanoic acid and eicosapentaenoic acid, which causes immunomodulatory action and decrease in the number of infections. And the one more thing which is important is the soybean oil and all, which leads to dumping of the lipids and which leads to parenteral nutrition associated liver disease, and that is decreased with this fish oil and olive oil. So there is an improvement in hepatic function due to these fish oil emulsions usage. Fats are again available as 10%, 20%, and 30% fat emulsions. So when you calculate a patient with 70 kg, the total kilocalories, when if you take 30% kilocalories per kg per day, the total kilocalories required are 2,100 kilocalories. Coming to calories from lipids, if you take it as 20% lipids, it amounts to 420 kilocalories. That is which divided by 9, it equals to 47 grams of lipids which are needed. And calories from amino acids, again, it is 1.5 gram per kg, 1.5 into 70, that equals to 105 grams and gives 420 kilocalories. And the remaining kilocalories, 1260, are given by the glucose, which amounts to 370 grams of dextrose. So the final volume which should be infused by this total parenteral nutrition, when it's a 10% stock solution, it is 1050 ml. If it is 70% stock solution, it amounts to 528, and with the 20% lipid emulsion, it amounts to 235 ml. So the total volume to be infused in a 70 kg body patient is 1830 ml per day. So infusion schedules, which is total parenteral nutrition, can be tailored depending upon the needs. Initially, they used to be continuous schedule. They used to be continuous schedules, and gradually the cyclic mode of infusion schedule has been driven. This continuous schedule is given over 24 hours, and it consists of less manipulation. But the thing is, patient need to be stayed at one place, and it adds burden to the patient and decreases well-being. When this cyclical mode of infusion schedule has occurred, this is more physiological. That is, the patient can do his work in the morning, and the infusion will be occurring for 12 to 18 hours in the night, which is more beneficial to the patient. Coming to the brands in TPN, which usually previously there are 2 bags systems, which includes amino acids and sugars. Now this is Kabiven, which includes 3-chamber bags with separate compartments, and the shelf life is 24 months. It consists of 2 clear liquid parts, which includes amino acids and glucose, and 1 white color part, which includes the lipids. This is Omega-1, which includes 10% emulsion of fish oil along with high percentage of omega-3 fatty acids. As I told, this fish oil and omega-3 fatty acid have an intense immunomodulatory actions and decrease in the infection rate and decrease in hepatic function. hepatic dysfunction. So this omega-1 has been a higher, reliable lipid emulsion compared to the soybean oil. This is amino-1, which is a amino acid preparation, 5% and 10%. It is a balanced pattern. It constitutes both the non-essential and conditionally essential amino acids. What are these conditionally essential amino acids? These are the essential these are the amino acids which are actually non-essential, but in case of sepsis, stress, or in case of critically ill cases, these non-essential amino acids become essential, such as glutamine, arginine. In case of stress, sepsis, these amino acids will be used up by the body, and there needs to be supplemented by outside. So they become conditionally essential. Actually, they are non-essential, and now they become conditionally essential. This amino-1 will be providing this non-essential and conditionally essential amino acids. This is SMOF. This is a lipid emulsion of 20% lipid emulsion, which is now approved by US people, which includes soybean oil of 30%, medium chain triglycerides 30%, olive oil 25%, and fish oil 15%. These combinedly have a great impact on the hepatic function, which is now followed in US, and it is approved by FDA. As I told, high content of essential and long-chain fatty acids are present in soybean oil. So this is the first commercially available intravenous lipid emulsion, and it has a pro-inflammatory effects. Now it is replaced by medium-chain triglycerides, olive oil, and fish oil, which has immunomodulatory effects. So the most dreaded complications of this central venous system, central venous catheter DPN is infections, that is CLABSI, central and associated bloodstream infections, which is reduced. The CVC infections can be reduced by patient education, hospital staff handling, and use of sterile techniques, chlorhexidine skin preparation, and again antimicrobial coated catheters may reduce the catheter colonization. And these practices must be done whether it may be home parenteral nutrition or in-hospital total parenteral nutrition. So coming to monitoring, before monitoring, I would like to discuss the complications. So initial 48 hours, the complications can be divided as mechanical, metabolic, and infectious. In case of mechanical complications, there would be malpositioning of the central line. There might be air embolism, pneumothorax, and blood loss, and there may be injury to subclavian artery, vein, and brachial plexus injury. And when it comes to metabolic complications, there may be fluid overload, hypoglycemia, hypophosphatemia, hypokalemia, hypomagnesemia, and refeeding syndrome. And when it comes to first 2 weeks, there might be thrombosis, air embolism, infections, and catheter displacement. And there might be acid-base and electrolyte imbalance. And coming to infectious complications, which occurs in the first 2 weeks, a catheter-induced sepsis. And more than 3 months, there might be air and blood loss, tear of the catheter, and catheter thrombosis. And metabolic complications, more than 3 months, they leads to metabolic bone disease and parenteral nutrition associated liver disease, such as liver steatosis and hepatic dysfunction. And in infectious complication, it leads to tunnel infection and exit site infection. So coming to monitoring, so based upon the complications, the total parenteral nutrition is associated with intense metabolic alterations. So the patients which have been instituted with total parenteral nutrition, the electrolytes, complete blood count, and glucose levels should be monitored daily, and renal function tests. When the patient stabilizes and enters the adaptive phase, this can be tailored to twice per week or thrice per week. The nitrogen balance, as needed for concern of underfeeding or protein malnutrition, it can be evaluated. But urine output, again, it has to be measured hourly in case of acute patients and every 4 hours in stable patients. So these are the monitoring which are essential initially in the acute phase, which is more important for this total parenteral nutrition monitoring. Coming to enteral nutrition. So this enteral nutrition dates back as far as 3500 BC, when the ancient Egyptians and Greece people, they used to provide the feeding therapy, enteral nutrition feeding therapy via rectum, and they make use of this wine, milk, whey, and wheat to provide nutrition. And later, Hippocrates and Plato also emphasized the importance of the diet. And Capavicius in 16th century, he was the first who placed the first tube for enteral nutrition. So, what are the enteral axis, which includes tube feeding, which includes nasogastric, nasoduodenal, and nasojejunal. And again, gastrostomy options, which include percutaneous, endoscopic gastrostomy, radiological, and endoscopic jejunostomy. And also it includes PEGJ, that is percutaneous endoscopic gastrojejunostomy. And the last resort is surgically placed gastrostomy and surgically placed jejunostomy. So these are the tube feeding examples, which includes Levin tube and Salem sum tube. Levin tube is a single lumen tube, and Salem sum tube is a multi-lumen tube, which has a tube for suctioning of the gastric contents, and again an air vent, which this air vent is placed for continuous flow of air and decrease in the trauma of the mucosa of the stomach. These are the tubes used for nasogastric suctioning and also decompression and also for feeding. There are nasojejunal tubes such as Dobhoff's tube and nasojejunal tubes such as Dobhoff tube and Millet tube, which are used for when stomach could not be used for feeding techniques, such as in case of delayed gastric emptying, in case of ileus, this nasojejunal tubes can be used. Coming to gastrostomy tubes, which includes PEG tube, low profile PEG tube, and OSG tubes. Coming to this PEG tubes, which are long tubes, traditionally these PEG tubes can be are used by endoscopic methods and surgical methods. Endoscopic methods, which include pull method, push method, and introducer method. And this low profile buttons or low profile tubes are the things which are available in with balloon and with no balloon. AMT Minion and Mickey one, these are the types which are available with balloon, and BARD is non-balloon type of low profile tubes. These are usually preferable in children with minimal handling of the tubes, and it has an balloon valve, and it has a extension tube. This button can be removed and the extension tube can be placed here, through which the feeding can be done, and again the extension tube can be removed and this button can be closed. The advantage is it has minimal handling and it is useful more in children. This is single step gastrostomy tube. Actually, the percutaneous endoscopic gastrostomy tubes are generally placed for 8 to 12 weeks, and then the PEG tubes are introduced. These are the supplements which can be given after 12 weeks. This is the endovive, which is the single step gastrostomy tube, which can be placed initially and need not be replaced. This is PEG-J tube, that is percutaneous endoscopic gastrostomy and jejunostomy tube, which includes 2 lumen and with the jejunal feed and gastric decompression. The gastric decompression tube will be placed in stomach for decompression of the stomach, and the extension of jejunostomy tube will be placed in the jejunum. It is useful both for decompression and in case of pancreatic or duodenectomies, which includes a decrease in the stimulation of pancreatic secretions. This has been a role. Coming to the enteral nutrition formulas, there are multiple formulas which includes elemental, semi-elemental, polymeric, specialized, and modular. Elemental formulas are nothing but the nutrients are given in their elemental form, and these elemental formulas are given such that it can be tailored according to the GI function. So in case of short bowel syndrome, in case of the dysfunction of the GI tract, this elemental formulas can be given. Semi-elemental are nothing but partially hydrolyzed polymeric feeds. Polymeric feeds are which are commercially available, Ensure, Boost. These are the polymeric feeds which are nothing but the nutrients are available as macronutrients such as carbohydrates, proteins, and fats, which are available in the macronutrient form. Specialized form, which includes specialized enteral nutrition formulas, which are available for specifically for renal diseases, hepatic diseases, and diabetic patients. These are the examples of Ensure. This is a polymeric form, and this is Ensure Plus, which can be the caloric needs which are given in this are 1 kilocalorie per ml, 1.5 kilocalorie per ml, and 2 kilocalorie per ml. This will be tailored depending upon the needs, and Ensure Plus can be given who needs calorie dense formulas. And this Vivonex, it is a elemental formula, and this Glucarna, it is a specialized formula which is given in diabetic patients. This is a formula given in hepatic failure. The nutritional needs are such that there should be higher proportion of branched chain amino acids and a reduction in aromatic amino acids and methionine, such that increase in aromatic amino acids, which leads to absorption through the blood-brain barrier and exacerbation of hepatic encephalopathy. So the aromatic amino acids must be reduced and branched chain amino acids must be in higher proportion. And again, the diet should be low in protein and calorically dense, that is more than 1 kilocalorie per ml. Coming to the leader and failure, this is a formula Magnacal Renal, which the formula which is used to decrease blood urea nitrogen and accumulation of toxic products while maintaining water and electrolyte balance. So in a pre-dialysis patient, low protein energy reserve is used, and in dialysis patients, high protein energy dense formulas can be given. So coming to the complications of enteral nutrition, no feeding formula, no feeding procedure will be available without complications. Even parenteral nutrition are associated with major complications. Enteral nutrition is not without complications. There might be complications with tube-related, GI, and metabolic or biochemical. So the tube-related complications are malposition, displacement, blockage, and local complications such as erosion of skin and mucosa. For this local complications and increased compliance, the button percutaneous endoscopic gastrostomy tubes have been devised, and GI complications, which include diarrhea, bloating, nausea, vomiting. And for these GI complications, the formulas which include elemental formulas are used because the feeds were directly fed into the jejunum, and when the feeds are directly fed into the jejunum, the GI tract cannot accommodate the polymeric feeds, and for which elemental feeds need to be given. And this metabolic or biochemical complications, which include electrolyte disorders, vitamin and mineral trace element deficiencies, which has to